And now I'm really very pleased to introduce Cecilia Oregon, who is the Executive Director of the Kaiser Permanente Institute for Health Policy. She'll be moderating our next session. Ceci leads strategy and operations for the Institute and focuses on access to healthcare for underserved populations and safety net systems. She earned her master's in public policy and her MPH from UC Berkeley, and she sits on the board of directors for Insure the Uninsured Project and Northern California grant makers. So Ceci, I'm delighted to turn this over to you and to let you know that our polling software is back up. So when we get to that point, we'll be able to use the Slido platform. So over to you, Ceci.
Great. Thank you, Margot. And I really also want to thank the previous panelists. That was an incredible session. I think that really, you could tell from the chat and the question and answer, it really stimulated a lot of thinking in this group. So I look forward to carrying over that energy into this session as well. So thank you for the opportunity to be here. As Margot said, I'm Ceci Oregon. I'm with Kaiser Permanente, and I'm really pleased to be part of this session today. Just thinking about what we heard in the last session was a huge number of ideas and thoughts that I think are really important. Again, I'd like to see if we can carry over some of those themes, but we heard about reducing the impact of structural racism on health services research, the white racial frame as used in the construction of our research questions, the methods and the interpretation, and really critical for us to rethink that frame. And then systems and institutions leading the conversation as opposed to community. I want to make sure that we think a little bit about that in this session as well. We heard about assumptions that white populations, and in particular white male populations, I would add, as the model population that we need to test against is a concept that I think we need to think more about. The definition of terms has been critically important, at every stage, really, I think. And intersectionality is a really critical component of how we think about identity and self, and how we interpret findings using an intersectionality lens. So this session in particular will focus on the misclassification and undercounts of race and ethnicity in health services research. And I'm pleased to introduce our distinguished speakers, but I'll just note that my brief introduction of them will not do justice to their extensive careers or honors that they've received over their careers. We will also have a brief poll before we hear from Dr. Inés Pons, who will tell us about her work to center racial equity in data systems by assessing different pathways to achieve the representation and visibility of more people. We'll then hear from Dr. Juanita Chin, who will reflect on Dr. Pons's presentation, and then we'll open it up for questions. And again, please continue to use the chat function throughout, and I'll do my best to keep up with the ongoing questions that we see both in the chat and in the Q&A section. So to begin, Dr. Inés Pons is an expert on immigrant and global health, survey-based research, social determinants of health, and health disparities. She serves as the director of the UCLA Center for Health Policy Research and principal investigator of the California Health Interview Survey, or CHIS. She is a professor of UCLA Fielding's School of Public Health's Department of Health Policy and Management. She's led numerous pioneering efforts in multicultural survey research, including measures of racial, ethnic identity, acculturation, generational status, and discrimination. She also has contributed extensively to professional societies, committees, boards that have focused on racial and ethnic disparities research. Dr. Juanita Chin is a sociologist and demographer in the population dynamics branch at the Eunice Kennedy Shriver National Institute of Child Health and Human Development, or NICHD, where she directs the demography of health disparities, human morbidity and mortality, and population composition programs. Dr. Chin co-chairs the NICHD Maternal Health Coordinating Committee, serves on the Trans NIH Unite initiative to identify and address structural racism, and served on the Federal Interagency Working Group for Research on Race and Ethnicity. Her areas of expertise include racial, ethnic, and nativity disparities in health, morbidity, and mortality, infant and maternal health, women's health, data policy, social demography, acculturation and assimilation, and the social determinants of health. Hugely incredible experts that I think we're about to hear from. So right now, I think I will turn it over to Priya to launch our next poll that we're hoping will help also inform our speakers a little bit about where our audience and our participants are today.
Sure, so thank you. This is Priya. You can access the poll by the link in the chat, and I will share my screen as the results come up.
Great. So a question, how would you describe your level of understanding about what groups are undercounted and miscounted in research and reporting? Basic familiarity, working knowledge, beginner, or expert? So it looks like we have a good proportion of folks, nearly half, with a basic familiarity, and then followed up by working knowledge. So this is great. And thank you for using the chat as well to help share your answers. This is great. And hopefully, again, this will be useful for our speakers as they think about the presentation. Thank you. Okay, with that, let me go ahead and turn it over to Dr. Ponce.
Thank you so much, Cecilia. And I think that was a long bio, but most importantly, is I've been with the Academy Health family since the beginning of my health services research career, and wanted to thank Academy Health for hosting this. And I'm very privileged to also serve on the Academy Health board. So this, stories were mentioned as being very prominent in the previous panel. So this is going to be a personal story about data, data and me, and pathways for representation and visibility, equity and efficiency in data systems. So 30 years ago, I worked on data disaggregation, and I'm still doing it now. So as part of my advocacy work with the Asian and Pacific Islander American Health Forum in the late 80s, we supported the Asian and Pacific Islander Health Improvement Act of 1990, sponsored by Norm Mineta, calling for the disaggregation of the Asian PI category into Asian, Native Hawaiian, Pacific Islander categories, specifically by the National Center for Health Statistics. And in 1997, the Asian/NHPI racial category was separated when the Office of Management and Budget revised the federal OMB data standards. Unfortunately, the UCLA Native Hawaiian Pacific Islander Data Policy Lab, which was just established last year, have been tracking COVID-19 cases and deaths, and about 27 states are still not OMB compliant. Either they do not report Native Hawaiians and Pacific Islanders or put them in a combined AAPI category or in another category. However they do it, it is not explicit in the data systems. So this hides the enormous toll of COVID-19 on the Native Hawaiian Pacific Islander population that we've seen for other states that do report out the NHPI group. For example, in California, Native Hawaiians and Pacific Islanders have the highest rates of COVID-19 cases and deaths. So we as health services, health policy community researchers are still reckoning on how disparities research has failed to achieve equity and has even contributed to the preservation of systemic racism. Certainly the previous panel has ably talked about this. Our data systems are the most robust on insights on what I call average consumers. So being data-driven, then consumers at the periphery become statistical outliers or casualties of omission and misclassification. And we have a tendency to lump racial ethnic categories or create a residual other grouping. And certainly this was happening in the national population surveys. Now as a researcher that is both a data consumer and data producer, I still believe that disaggregation of race, ethnicity, and public health data and health services data is pivotal to understanding the vast experiences across racial ethnic groups. And more so than other healthcare data sources, population health surveys ask about living conditions, education, occupation, income, trauma history, piecing together this backstory that could be generational, that may explain the racial ethnic inequities in health access and health outcomes. This is especially critical for those who would be otherwise unseen, neglected, and hidden in an aggregate group that belies unknown risks. So as data producers, we strive to get the story right. This means it is unbiased and more precise identification of racial ethnic group affiliation. And I do this through my bread and butter job at the California Health Interview Survey, or CHIS. CHIS offers an example of how population health surveys can effectively gather and analyze data about small racial ethnic groups to inform policy and programming. Conducted since 2001, CHIS is the largest state-based population health survey in the United States. And consistent with federal guidance, CHIS collects subgroup data within the Hispanic, Latino, the Asian, the Native Hawaiian Pacific Islander, and American Indian Alaska Native racial ethnic categories. And for American Indians and Alaska Native, we collect information on tribal enrollment in state or federally recognized tribes. Starting this year, we have a write-in category for the white and Black populations. So the CHIS uses oversampling to ensure that sufficient numbers of Asian and AIAN individuals are included in data collection procedures. In addition to English and Spanish, we also conduct interviews in several Asian languages: Cantonese, Mandarin, Korean, Vietnamese, and Tagalog. And such strategies facilitate participation by a diverse cross-section of Californians with various immigration histories, socioeconomic levels, and economic opportunities and contributions to society. Plus, as a survey research methodologist, it reduces coverage bias. So data also doesn't sit on the shelf, and our data is available as public use files and also as free web query systems called Ask CHIS and Ask CHIS Neighborhood Edition. Data disaggregation has led to important health policy reforms. For instance, these data allowed English language proficiency by race ethnicity, for example, among Mexicans, Chinese, Vietnamese, to be tracked among Californians. This was critical to the drafting of the 2003 California's Healthcare Language Assistance Act. And this act was the first of its kind to require health plans to collect data on enrollees' race, ethnicity, and language. Medical errors due to communication barrier harms people and health systems, and more precise measurement of language assistance need is a way to reduce cost. Other examples are in better targeting of outreach to specific groups. For example, uninsured Koreans, Filipinos with high rates of mental health care need, and these needs would be hidden in aggregated data. So other public health systems do not routinely disaggregate race ethnicity data further than the OMB guidelines. But the OMB guidelines are a floor. It's not the end all, but it's a floor. So under COVID-19, only the state of Hawaii reported public-facing disaggregated race ethnicity data. No other state in the United States did. But when you access the restricted data, as I did in California, it did show that Filipinos within the Asian category had experienced the most deaths than any other group, especially among health workers, most deaths per capita. But there is a time and money transaction cost. This is something I think we could discuss here to access restricted data. Certainly a project that I did actually with Rashida on looking at building capacity for American Indians, Alaska Natives, part of the takeaways was that maybe the data is collected, but it's in restricted space, and the transaction cost is high for researchers that want to expand the insights on these smaller groups. So, and with this pandemic, we saw that better access to disaggregated data could have helped in timely policy action to save lives. And these transaction costs imposed are like a tax on gaining insights for some groups that could further widen inequities in health. centering equity in our world of health services research means that there is an explicit measurement objective to eliminate health inequities. The CHIS is co-produced by community-based partners, and we heard that in the previous panel. Very critical in getting the measurement objectives right. And this we do this through advisory committees. CHIS is also a public-private partnership that is a mix of government and private funders. So this diverse portfolio of sponsors and stakeholders makes sure that we listen to many points of view and the quality of the data is better. I close by underscoring that in the allocation of resources, both equity and efficiency criteria are achieved with disaggregated health data, and that CHIS could be one model that shows it can be done. So thanks for listening.
Thank you. Dr. Chin?
Yes, Inez, I thought that was wonderful. Listening to you speak, many things start coming to mind. And you started off with the topic of the kind of the OMB categories and the importance of disaggregated data. And you mentioned that some data collections do use collect and report disaggregated data. I think it's important that people know, and I think you mentioned this, that that's just the basic starting point, that these data collections can disaggregate the data as they need. But one of the purposes of the OMB categories is to make comparison across data collections possible. And so how can researchers that want to look at disaggregated data and want to report on disaggregated data also ensure that their data can be compared across multiple data collections? Is there a resource available?
Thanks, Dr. Chin. There are resources available. There was a IOM 2007 report which was disseminated and promulgated more, and it showed how each state or locality could collect, beyond the OMB standards, but suggested several models of a roll up that would roll up to the 5 OMB categories and the Latino race ethnicity. And I can put that in the chat. It's actually 2000, published in 2009. And there's also roll-up suggested by the census. I think that there are resources available. Again, I think it just has not been encouraged, it hasn't been disseminated. And the other part of that is that, there isn't really an appropriation or a fund incentive to collect, more granular categories. And so California does have, in state laws, does have a suggestion in collecting even beyond the OMB categories, but there's no accountability handle. There's no penalty and there's no incentive. So that's also part of the problem.
Yeah. And I know, like, with COVID-19, a lot of kind of jurisdictions that were reporting on their COVID-19 cases, diagnoses and deaths, at the start of the pandemic had difficulty even just reporting on the 5 racial and 2 ethnic categories. And so a lot of kind of that areas of understanding disparities in the COVID-19 disease were missed, as you mentioned with the California example, looking at the Filipino population explicitly and how it was different from the broader Asian category. And so when looking at particular diseases, looking at kind of who gets missed, who is not counted when looking at disparities. And you mentioned the Native Hawaiian population and Pacific Islanders, and that triggered me to think about what we know about maternal mortality and also infant mortality. So we know that infant mortality rates for Asians are comparable to those of non-Hispanic whites. But when looking at infant mortality of Native Hawaiian and Pacific Islanders, they're very disparate relative to non-Hispanic whites and relative to Hispanics very broadly. But when we report maternal mortality, Asian and Native Hawaiian and Pacific Islander are grouped together. And so that disparity in maternal mortality, maternal morbidity goes unnoticed and kind of unmentioned. But we know that infant mortality is very reflective of maternal health. And so that's a disparity that's being missed because of how data are reported. And so that's another example of what you gave us when we don't report on that disaggregated data. And even so, that's an OMB category, right? That's not even a disaggregated group. That is one of the aggregated categories. And so I guess and that group, you mentioned your history and your experiences with that group of that category, Native Hawaiian and Pacific Islander, becoming one of the OMB reporting and data collecting categories. What happens when we have these groups that numerically are small in number, and then they aren't being reported on? Even if they become a data category with OMB, we do not receive that information. How can we kind of push towards receiving, collecting, and reporting on those categories and on those populations?
Yeah, thanks, Dr. Chin. So yeah, what I had posted was the collection, and it's the reporting that then gets us into the space of privacy, confidentiality, statistical reliability, and assuming that these health data systems are continuous. I mean, they're done yearly. So one strategy, which I've done in my papers, is to pool several years of data. So one would be pooling of data. And the other that we do in CHIS is we oversample. So we oversample for American Indians, Alaska Natives, for example. There's a point where it becomes just not cost effective at all. I mean, the Native Hawaiian Pacific Islander population is a very small population. It's less than 1% of California's population. So that special study, so we are doing a special survey as the National Health Interview Survey did, and they did a Native Hawaiian Pacific Islander health interview survey that resides in the Office of Minority Health, the Federal Office of Minority Health. That it's so sometimes the special samples then would be needed to get insights on those group. Because oversampling, could be expensive. It could be inefficient from a design perspective. Because then it's just effective sample size, goes down, and it may also employ methods that may not necessarily get at a population representatives of a sample. So, for example, we looked at two ways of oversampling American Indians, Alaska Natives in California. One was registry-based, if they had used any services from IHS, Indian Health Services, but then that already biases what if you are not from a tribe that provides services in California, or you're not in an enrolled California tribe, then it would miss out on some groups that aren't part of that registry. So, and another was to do some predictive modeling, which I'm sure that could be a whole other discussion on what the inputs are on predictive analytics, by looking at census data, American Community Survey data on where people live by race, ethnicity, and doing some predictive modeling and targeting those areas. again, the drawback of that is that if the data you're using, such as the American Community Survey, has already had some criticism on undercounting Native populations, then that already, again, biases your predictive modeling, the design of your predictive modeling. Whatever we do, whether it's predictive modeling or looking at registry-based and also working with community organizations, that we do try to involve, again, like nothing about us without us, the stakeholders involved in trying to get at the insights that we're trying to generate. And then the last piece is that, as I said, this data is collected. I mean, California does collect data on Filipinos, on these granular groups. They collect this data, but I had to wait 4 to 6 months to get that data and pay for that data. In the COVID data, it wasn't particularly that expensive, but in some of the data in the federal systems, you have to go through a census, like research data center, hoping that there's like one near you, so you don't have to fly out to DC. And then there's another data cost with the whether it's CDC or CMS. So there's other data. So there's all these transactions, and so I think, as I said, one way is like to ensure that there's access to data for smaller populations for researchers without such a high transaction cost. So oversampling, pulling data through several years, special surveys, and lowering the transaction costs for data access.
Yeah, and I think that kind of payment model of how researchers access data and how data are made available to them is important, not just for kind of race ethnicity research, but for research on other vulnerable populations. But I also want to kind of, oh no, go ahead.
Sorry. So and I was going to say, it's also not just even race ethnicity, but say you wanted to look, again, about intersections, right? So then if you want to look at Black domestic, foreign-born Black domestic workers, which were hit by COVID-19, then you couldn't necessarily get it in public-facing data. You'd have to go through restricted data.
Yeah, and data at that intersection, even race and gender, right? Like not even including nativity as an intersection point is hard to find in reported data, right? That's data that people usually have to run on their own. And so reporting at the intersection is critically important because you may see a nativity, you may see race and outcomes, ethnicity and outcomes, gender and outcomes, but you very rarely see kind of that race by gender or nativity by race and the health outcomes being reported. And so the information that we do know about that is because researchers ran that data. And as you said, they're privileged to have access to that data.
Yeah.
But just to pivot a little bit, a lot of what we talked about is in these kind of survey formats where data are self-reported to the interviewer. But we know that there's misclassification and undercounts in observational data and data of observed race and ethnicity. And the example I give is in the death certificates. So particularly for Indigenous populations, Pacific Islander populations, and Hispanic populations as well, though I think that's gotten a little bit better over time. And that leaves a dearth in reporting of, say, national level life expectancies, where we don't have information for all populations. And also, and another example that I give is in teen suicide rates. Our data show so far that it's high among, for young adults, adolescents, and teens. Suicide rates are high for Indigenous populations. But even more troubling is we assume that that is an undercount, that that data is actually probably more prevalent. Higher rate, the rates are probably higher than what we calculate because the pervasiveness of misclassification of Indigenous populations is so high and regionally based, right? So in areas of the country that have high Indigenous populations, the undercounts and misreporting are not as pervasive as they are in areas of the country with smaller Indigenous populations. And so just trying to, I guess, talk a little bit about kind of self-reporting undercounts and misclassification relative to kind of observer reported undercounts and misclassification and the impact of those.
Thanks, Dr. Chin. You raised on a lot of the data, not so great quality issues. And on death statistics, the I think there has been, I'm not exactly sure about this, but if there isn't, there should be more of a more training to funeral directors. So funeral directors are the ones filling out the death certificates often. That that there definitely should be a consultation with families. But of course, with COVID, right, in many cases there wasn't consultation. And the other problem raised with Native Hawaiian Pacific Islanders and American Indians Alaska Native is that those two racial categories have over 50% that are multiracial. So so then race assignment is by color of your skin, which we know should be self-reported, and so it's street race, and if we're Latinos, it's street race. So it becomes how you're perceived, on the street, and it's so first and foremost, as we put in the IOM report, is the gold standard is self-reported. It's self-identification. Oh, sorry, Cecilia, did you want to say something?
No, go ahead. Finish this thought, and then I'd love to ask one of the questions from the attendee.
Oh, okay. I know that there's, race, ethnicity data in claims is just notoriously bad because it's misclassified or missing. When I was on the this IOM subcommittee, it was 70% missing. I don't know, I think it's probably improved a bit, but it's still pretty bad. And so imputations then are one way of filling in this missingness. And those imputations then seem to perform better or validated, as you said, Dr. Chin, for the larger populations groups, but not so much for American Indians, Alaska Natives, and Native Hawaiians and Pacific Islanders, and possibly for Latinos too, again, because of the confusion with, or a high rate of putting other, versus one of the five major racial groups. So what I'm hearing is happening, and I kind of heard this is happening in ASPE, and we're going to fund a small project with Colorado Health Institute through an RWJ grant on racial, improving racial ethnic data, is to use surveys which are self-reported and using some of that in helping with the imputation of or linkages with other data sources like claims data. So we're thinking of funding Colorado. I don't know if anyone's from Colorado is here. Haven't committed yet, but we're thinking of funding Colorado because Colorado has an all-payer database and has a Colorado health assessment survey. So, and I mentioned this to a talk I gave to ASPE about a few weeks ago, and they said they were also thinking about funding these studies where self-reported race ethnicity then informs other data systems that either are assigned by someone else or just by standard operating procedures, just kind of default to putting other in their data systems. I think you had more, but maybe I'll give a pause here and ask Cecilia.
So it does sound as though there is a question about in what states do funeral directors fill out death certificates? And then there's just another comment about the gold standard being self-identification and need to understand observed race, as racism is largely about how people race you rather than how you self-identify. So related, of course. So are you familiar with a number of states that do? Okay.
I don't know the state kind of rules, but my understanding is that death certificates are filled out by whomever can fill them out. So it's not always the funeral director, though oftentimes it is. It could be the physician, it could be family, it could be next of kin that identifies, but that's not always the case or not always available either. And so I don't think that if there is a rule, I don't know that that's what the de facto is or what's observed in practice.
So we do also have a question. So are there trade-offs between using more granular categories and item response rates for questions about race and ethnicity? Or is there evidence that item response is better with more granular categories? What are the pros and cons of inputting missing race and ethnicity data?
Okay, so before I answer that, I think the other question was about how people perceive you is the measure of structural racism. My colleague Nancy Lopez from University of New Mexico has been really trying to promulgate this idea of measurement of street race, particularly among Latinos. And it's something we're considering, so that in a survey, not just what is your race, are you Latino, Hispanics, the first question, follow OMB standard, and then we go into the 5 categories. Yeah, but asking that how do people perceive you? I don't exactly have the syntax, the wording, but I've heard a lot and read what she's done that it's making me thinking that maybe we should look about how what race people perceive you.
Yeah, and given that the Black-white differences in health outcomes within the Latinx and Hispanic population, that street race is critically important. There's infant mortality disparities, health disparities by race within those populations, so that lived experience based on skin tone or racial identification are critically important. But also there's some older work by Kamara Jones that talks about the importance of how people perceive you and what that means for your health and health outcomes. So my point of view is that both are very important, but I think very few surveys get at kind of your perceived racial identity, and also that's very contingent upon who's perceiving it. So the racial and ethnic identity of the surveyor, if they record how they see you, it's important to record how they identify and understanding that as well. I'm sorry, didn't mean to cut you off, Nina.
No, no. I think it also adds to some of the comments Juanita saying. So on the question on the trade-off from granular categories and item response rates, we haven't done an explicit test on that. Where we could do a split sample in the survey where some of our respondents get only the major OMB categories and some the granular categories. I can say that what the granular categories do is capture some groups that may not see themselves in these socially constructed buckets from the census. And an example, being Filipino, is that I have relatives that think that they would put Pacific Islander because we're in the Pacific, and that do not associate themselves with East Asian or South Asians, and so we're not part of being educated here and being in universities with ethnic studies movements and the Asian American movement, so do not identify as Asian American, but identify as Pacific Islanders. And so if we just had the 5 categories, then there would be, more misclassification that can occur. And that's actually happening a lot in California. There's misclassification between Filipinos and Pacific Islanders, Native Hawaiians and Pacific Islanders. In terms of item non-response rate, our race questions, I don't have the number offhand, but I want to say it performs as well as our citizenship. We have some sensitive citizenship questions on whether you have, whether you're not, you're born here, naturalized, whether you have a green card, and non-response rate for that is probably no more than 5%. It gets higher, once we get into the green card question. And so I think the race, questions are, we do imputation, but I'd say it probably isn't more than 10%. And that's the most. Missingness for race is not as bad as missingness for income. Income could be 25% missing. It's like the variable that most surveys are vexed with, because it's missing. So I don't think collecting is going to lead to problems of non-response rate. I do think that's what we're finding right now, and it's new because in 2021 we started asking the write-in of whites and blacks, and that's because we're following the census, and based on this, then we may next year have a separate Middle Eastern North African category, a MENA category. But for blacks, it seems to be not a cognitive load to say, that they're Haitian, Nigerian, like what group. For whites, it was more of a cognitive load, like trying to think back, like what all the different ancestries. So that's what we're seeing preliminarily, but we haven't collected data yet for all of the data for 2021.
Mm-hmm. One thing that we chatted about as we were kind of preparing for this, and that you've brought up a few times, Inez, is the census. And just in fact, right now, the current conversation around differential privacy versus accuracy, and a number of states have stepped forward, including Alabama as the primary state, to sort of argue about differential privacy and its use. And so I know that just given our poll results, I was wondering if one of you could lay the groundwork for part of this, and then the implications for the use of differential privacy as we think about gathering this type of sensitive data and trying to make efforts to secure privacy moving forward.
Do you want me to give it a start, Juanita?
Yeah, you can give it a start and I'll chime in.
I'm not sure I completely understand it either, but this is my very, very high level and possibly cursory understanding, is that it's, the census had, put out in the world that there would be this statistical method of adding noise to data to, ensure that, well, what I think was to ensure, data access. So, and this is, differential privacy is part of a disclosure risk mitigation. It's a type of, what we call perturbation of the data before it's released. And any kind of, so a data custodian, data producer would be releasing data that is not, that has some noise, so it's not the, the real data. And there's of course, from a data consumer point of view, there's a lot of pushback from that, because how much is that noise? And so data consumers, want to know, if you are going to do noise, and you at least need to tell me, because then our estimates could be flat out, incorrect, and not high fidelity to what the respondent, participated in, what they said. So the problem with that is that it affects smaller groups. Is that and in some ways it is a way to protect, to provide access for insights on smaller groups. So it does seem like a trade-off between access. Do you want the data even though it's noisy, but you have access to it, or do you, do the same, standard operating procedure of seeing reports and your group is not in the reports, and so, or you have to go through the many hurdles of getting access to that data to get at the restricted data. So that's my very cursory understanding of it, is that also what this, how much the noise is of course going to affect the smaller groups, right? Because the larger the noise and the less fidelity it would be on the insights for that group. Where I'm in the shady space, Cecilia, is I had heard that it's not even clear that this differential privacy is going to lead to better data access. That you still have to go through that, and maybe Juanita can clarify that. So I'm not completely against differential privacy, as long as also that the noise is informed by researchers that work with the communities where this differential privacy is, being applied, to really understand what the inputs are in creating that noise. But also that it then allows for better data access.
Yeah, like Nina's, my understanding of the census differential privacy algorithm is high level. But there are a few key points, like Nina said, is that, even when we report on our survey data, if your N is less than a certain number, you suppress that data, right? So I think the algorithm was a way to kind of suppress less data, right? So that you can have, but the issue is, like, census data are used for denominators in different population estimates. And the census, and health researchers use that data and those denominators in their estimates of health disparities and health equity. And what it's shown that it drastically changes the population counts of racial, ethnic minorities, particularly in non-urban settings. So in these small areas, small population estimates are greatly impacted by this differential privacy algorithm, which is kind of intuitive of what you would expect, right? Because that's what suppression and data privacy, that's how it operates. But caveat, this is not implemented. This is not an implemented algorithm. This is something that Census has made public. This is something they're considering, that researchers are, and their researchers too, are providing feedback on. This is the unintended consequences of this new algorithm. And one of them is that it will impact what we see in our disparities and our equity and our minority health data and research. And that's a consequence that we don't want. And so many researchers have actually used the algorithm that's available to quantify and measure. And we see this, I think Santos Lozado has a paper out on it, and quite a few others. And so I say this is because this is a vulnerable group that has the potential to disappear, right? And in the data. And this is something that, given the topic of this workshop, is critically important, right? So they were visible and now they may not be, right? It's like the wrong direction that we want to go. So even in doing your data research, and as a graduate student, I definitely was guilty of it, was the data and the people were completely distinct from each other, right? I did not always make that connection as a quantitative researcher, right? I ran my data, but I'll think about the people in my theoretical section. And I think that when you're doing these data collections, you have to think about the multiple uses of this data and how you're impacting people, and particularly the vulnerable populations, right? When we talk about kind of this misclassification, that's who we're talking about. When we talk about small area estimation, when we talk about health, disease, inequities, when we used our COVID-19 examples, we used our examples with maternal mortality and infant mortality and many others. These are the groups that are being impacted. The numbers of that population are small, but then they have to advocate for themselves, right? And so you're forcing these groups to then advocate for themselves because people are not considering health disparities and health equity when research is being designed and when data collections are being designed, and those are critically important. So this is not an attack on census. They made this available. The researchers are supplying them with this information so that they can go back, recalibrate, adjust the algorithm so that you can achieve both not kind of tweaking what we know about health disparities, but also achieving kind of this data privacy and lowering the risk of disclosure necessary to report on small populations. And that's my kind of high level understanding of this algorithm.
That's great, thank you. So I will just point to, in the question and answer, Allison Lacko has given us an array of questions to consider. So let me see if I can try and summarize a few of these and see if we can get your thoughts quickly as we start to try to wrap this session. But her questions: how can we act on this? What can we advocate for? For example, many federal agencies sought input on how to assess the equity impacts of their programs. Given limited resources to conduct national surveys, what should be prioritized? Funding to implement better sampling strategies, making pooled data publicly available, reducing barriers for access to restricted data. Are there others? Are there other calls to action? And then a question on: how do you think about data sovereignty and ownership for data collected among tribal members? And I know that's also something we've talked about. Can tribes or native-led epidemiology centers be granted special access to restricted data? So there's a number of things to sort of work with there, and I'll just ask each of you if there's one or two really compelling thoughts that you have as related to Allison's questions. We'd love to hear them.
Well, first, it makes me want to get to know Allison more. Thank you. I also want to point out that I liked what Ariana put, that the Census Bureau differential privacy algorithms are a solution in search of a problem. That may not have been their intention, but that's kind of what it's getting at. So Allison put forth what I had suggested about oversampling, data access, and I think that there is a House bill right now by Presley that gets at data disaggregation. I'll try to look for it or put it in, once this session ends. And the data advocacy is important. In California, there was data advocacy for the disability community and data advocacy for sexual orientation, gender identity, identification in the COVID data. So there is a role for data advocacy, but as Juanita said, you don't, and I know that in some discussions I've had in this RWJ commission on transforming public health data systems that I was part of, is that, we believe fundamentally that the public health statistics is the responsibility of government. But then government needs to listen to the data, the population that, again, it purports to represent. And so unfortunately, this data advocacy, though, maybe stronger in some localities, some places. I mean, California has a strong advocacy network and health equity network, and it may not be as strong in other states. So that's, I think, the downside of that. I think having health equity grants, I mean, now we're talking a lot about equity dollars, particularly after COVID, and what we saw in COVID and with the recovery that's needed so that we don't perpetuate, and in some ways we can reimagine a fairer society, then it's that the equity dollars that came in California went to groups that tended to be underrepresented. And these groups, actually, one of their priorities was better representation, better visibility in the data, because they knew what was going on in their communities, but they really could not compel policymakers to put attention on their unmet needs without having the data. So, so I think the equity dollars going to data equity, particularly for these invisible groups, or getting at the intersectionalities that we don't see, as Juanita said, yeah, even just gender, would be really great to see in public facing data. I think another, that's under sovereignty. Yes, absolutely. I don't know enough about this, but I didn't know that native-white epidemiology centers should they have access to special data? Yes, so they have access to the data that they collect. But yes, I do think special access to the federal surveys, the CMS data, AHRQ data, on MEPS data, for example, and all of the HCUP, all the physician and practice-based data. I think that they should be granted special access without the the transaction costs that are imposed. So I agree with that, Allison. Sampling strategies. Yeah, sampling strategies. There's APOR, American Association of Public Opinion Research, does have a strong multicultural survey component, and there are a lot of discussions on better sampling strategies now for smaller groups. I've revealed some of our challenges and shifts for the American Indian Alaska Native population, but I think that there's yes, better sampling strategies, I can just say, we've been thinking a lot about that. In federal data sets, we're almost time. I see Margot coming on. I can talk about the sampling strategies maybe offline. And what should be prioritized? What should be federally, I think what should be prioritized is the goal to present data for at least 5 OMB groups. And if that's the goal, then the process of getting there, whether better collection, oversampling, or better, or for BRFIS, for example, which is federated, better incentives for states to roll up, to provide this granular data, then I think that those would be the steps that would occur.
So maybe
And
we
just 30 seconds on the reducing barriers for access to restricted data. I think it's important to reduce financial barriers to access to restricted data, but the data are restricted for a reason, right? And it's the disclosure of participants' information that needs to be protected so that we can continue to collect that data and establish and maintain trust in data collection. So I do think that, some barriers are necessary with restricted data, but the financial barriers should be reduced.
And I know we're at time, so I just want to thank Dr. Pons and Dr. Chin for joining us and having such a wonderful conversation about this important topic. So I'll pass it to you, Margot.